You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello, and welcome to the Lipid Legends podcast series. This continuing education series is supported by an educational funding provided by Amgen, Arrowhead Pharmaceuticals, Inc., and Novartis Pharmaceuticals Corporation. I'm your host, Dr. James Underberg. I'm a clinical assistant professor of medicine at the NYU Grossman School of Medicine and the NYU Langone Center for the Prevention of Cardiovascular Disease. I'm the director of the Bellevue Hospital Lipid Clinic and past president of the National Lipid Association and American Board of Clinical Lipidology. And I have the pleasure today of being joined by a friend, colleague, and one of my mentors, Dr. Howard Weintraub, a clinical professor of medicine at the NYU Grossman School of Medicine, clinical director of the NYU Center for the Prevention of Cardiovascular Disease, and associate director of the NYU Preventive Cardiology Fellowship Program. Howard, thanks so much for joining us today.
Thank you for asking, Jamie.
So in this Lipid Legends podcast series, I have the distinct pleasure of interviewing expert physicians and researchers on topics that are of current importance in the field of lipidology. And today we'll be discussing the role of lipoprotein A in atherogenesis and the potential impact of emerging therapies that target lipoprotein A. We'll be calling it, just for the purpose of brevity, LPA. And if you hear us use LPA or lipoprotein A interchangeably, it's the same thing. And also, Dr. Weintraub and I know each other very well, so we'll be using first names. I'm Jamie, he's Howard, and we've agreed to do that ahead of time. So Howard, to start us off, how did you end up in the fields of preventive cardiovascular medicine and lipidology? What was your pathway to where we are today?
Sure. So when I was a resident, I couldn't make up my mind between pulmonary and cardiology. So the then chair of medicine, Saul Farber, said, why don't you do both fellowships? So I did. I did a year of pulmonary first, decided that investigating sputum was not something that I wanted to pursue for the rest of my life. But I did enjoy pulmonary physiology, went on to then work in the exercise lab. And then there were these lectures that were being held by Tony Gatto and other people who were in part of Framingham and part of the nascent specialty of lipidology. And all of a sudden I saw my patients and I saw an interest. I saw that there was syndrome X, as we called it, or mixed hyperlipidemia. And everybody I knew, or saw rather, had a big belly, a low HDL, a high triglyceride, and a moderately elevated LDL. I said, eureka. I got interested in that. There were vascular biology programs. And then one thing led to another. And then they migrated several people from Sinai, as you know, and we formed the Center for the Prevention of Cardiovascular Disease. You were one of the first joinees. And we had our meetings, we had our symposia, and it's been more than 15 years, and it's been a great ride.
So you've had obviously multiple amazing accomplishments in your career. I've been witness to many of them. Now, what career achievement are you most proud of?
Well, that I'm still doing it is a pretty good trick, number one. Number two, the fact that in a field of intervention, which is cardiology, my intervention is preventing interventions. And that has been a victory on my part. And also, it's very nice to see that the world has come around recognizing preventive cardiology and, lipidology and the importance of what we do has become that much more accepted. And I think both you and I have been at a part of our careers where we've been able to witness this and be part of it. And Jamie, you had a huge role in shaping it. it's with your role with the NLA. So you can speak the same way I do, that it's been great to watch the specialty grow.
So one of the exciting things about the space we live in is that it's constantly changing and morphing. And if you and I were to have this conversation 5 years ago, we might have been having a conversation about something entirely different. But the topic at hand today is lipoprotein A, and it's a space that you have really started to own as someone whose expertise in this field, both from the physiology, pathophysiology, and the perspective of clinical research and interventions, which we'll get into. But why is LPA getting so much attention lately? Could you go through some of the risk factors and the epidemiologic data and maybe some of the unmet needs around it?
So just to briefly start out, I heard Dr. Samikas speak on this years ago. And back then, people viewed his preachings as unique. And what is this guy talking about? We're just trying to figure out what LDL is. And now he's going with Lp(a). So it is, like many other things, it resonates. The same way that the field of lipidology was exciting to me. There was something I could treat. It made a difference long and short term. And I think Lp(a) has been, as many have said, it's LDL on steroids. And it is something that explains so many features of atherosclerosis. And it is something, again, that made me feel, A, that I was doing something unique, B, I was doing something useful, and C, that it was going to have an impact in the present as well as in the future. So this is a molecule that is an LDL, literally, it's an ApoB-containing molecule that has covalent bonds to an apolipoprotein called apolipoprotein(a). And it is something that is not exactly rare. Jamie, you are one of the world mavens in FH, and we look at numbers of things that happen in the hundreds of thousands. This is 1 in 5 people. So this is something that you don't have to go a full day in the office. You don't have to go more than 2 or 3 hours, and the chances are you'll see somebody with it. And it's odd that patients have been very motivated to follow with this. And interestingly, our colleagues have been a little bit more difficult to convince. But it can play a very big role in coronary heart disease, a little less in stroke, and very prominent in calcific aortic valve stenosis. So it's there. And the trials have been going on. Opportunities have been there to shape therapies and interact with colleagues. It's been a very good time.
So speaking of colleagues, how are clinicians incorporating LPA into clinical practice? Where are we with testing rates, conception or misconception about actionable options right now, and where are we moving with regards to things like family screening, et cetera?
I have seen more traction with primary care with some of the internists that refer to me. I now see that the patients are coming to me with an Lp(a) and an ApoB. So I feel like I've done my job, yay. And they're no longer getting as much of the LDL particle stuff. But interestingly, our colleagues, Jamie, you tell me stories constantly about cardiologists whose patients you'll see, and you're just astonished as to the absence of certain things that they should have looked for. I still find that. And I think cardiology is very much based upon a catheter, whether it contains an electrophysiologic measurement or whether it squirts dye and then puts a balloon or a stent into something. And that is what happens. We wrote an article together several articles together looking at the failure of some of our brethren in doing a good job in prevention. And we wrote an article about Lp(a) in people who were recurrent with another intervention within a year, and the majority of them had a high Lp(a). And it's amazing that the message doesn't get out.
With regards to understanding guidelines and what's out there right now for clinicians to latch onto, because you and I both know that sometimes we'll get back from patients, why should we test it? There's nothing to do for it. So I want you to address, A, what are the current guidelines right now? And then what can we do for it right now if we know about it?
Interestingly, the Europeans, the EAS, and actually the Canadians were first to hop on the bandwagon. The NLA, to your guys' credit, rapidly came behind them. And I just spent 2 years advising with the AHA in this discovery project of, quote, experts that were trying to develop strategies to have people embrace what Lp(a) is, and the fact that there was no specific drug that clobbered Lpa levels, say like statins or PCSK9 inhibitors, should not be the reason to ignore it. If anything, you have a lot to do to make sure that the housekeeping you do is all appropriate, and every other risk factor is in line, awaiting several drugs that are nearing the end of their development.
So what cutoffs would you use for elevated Lpa, and what cutoffs would you use for risk associated with elevated Lpa? And are there different numbers people need to know?
Absolutely right. So let's, number one, we're talking about numbers. There are two different measurement systems. There was an article in circulation that was Henry Ginsberg was one of the chief authors, and actually Sean Heffron from our center was one of the authors. So they advocate for nanomoles, nanomolar measurements, which is useful because you get an idea of the number of particles. And one of the characteristics of Lp(a) is that particle size matters, but it's inverse. The smaller ones get you in trouble, the bigger ones not so much. So the number there is 75. So it's not like 74 is good and 76 is bad, which unfortunately is something we need to get across. So there is some traction of risk starting, below 75. And because of the risk is not completely linear, and as it goes up towards 125, the risk starts to accumulate, and above 125, it accelerates. And if you look at the data from Nordiscard, if you look at the data from Semikis and other individuals, when you get a number that's 3 or 4 times the upper limits of normal, you have a risk that is 3 to 4-fold for the development of coronary disease.
I've read, as you have, that when you compare the risk related to Lpa to that related to ApoB, it's significantly greater, correct?
Correct. And it's the intimate interaction with what we call oxidized phospholipids, particularly ApoB containing oxidized phospholipids. Now, this is a fancy sounding term, but it is one that shows places where we should be looking, and the place where some of the gurus are looking already.
All right. So we've talked about Lpa levels, 75 nanomoles, 125, risk takes off. If you're still doing milligrams per deciliter, 50, but there's a movement towards most labs doing nanomoles per liter. So someone comes in and they have elevated Lpa, or you've just found it in one of your patients. We know there are no medicines as of today approved for Lpa. So what is your current therapeutic kind of pathway with the person who comes in with high Lpa right now? And why is it worth knowing about it, independent of the risk?
So what this more or less means at that point is that I'm going to make sure everything else is in line. This is where, if you were I was about to use davening. If you were trying to decide whether you were going to, treat an LDL that's above 100, but say below 130, and you had no other motivating features, the LP little a can be very motivating. And so it means that you're going to do whatever you can from a lifestyle perspective. Obviously, age is a factor here, and gender. But in many people, it means a statin. And it means that this is the way that they're going to be able to have a lifestyle that in their mind is livable, and not one where they keep coming back complaining about the vacation, the bar mitzvah, the sweet 16, or the cruise that they just took, and why it explains their 30 milligram per deciliter rise in LDL or what have you. And then it's correcting everything else. Stop smoking, get thinner, exercise more, watch your blood sugar, watch your blood pressure. And if you can figure out a way to do it, make sure your genetics are good, because this is one of the things I think that is overlooked as we're all trying to figure out what to treat. And that is namely to make sure that the kids or your siblings are aware of the diagnosis. To me, it would be a better choice to talk to a 15-year-old about lifestyle and diet rather than playing what I call catch-up baseball, where, you're trying to do the best you can to convince a devoted McDonald's aficionado that they shouldn't be doing that as much as they were.
This is such important information because, again, we both heard people say, oh, I was told, why measure it? There's nothing to do about it. And you just elucidated a very comprehensive list of things that one can do about it, managing all the other risk factors, family screening, getting people's LDL controlled. There are two things out there today that will lower LPA. One not approved, which is PCSK9 inhibitors. They lower LPA about 25 to 30%. And the other is apheresis. Have you used either of them in this setting?
Yes, I have. There are several people that have seen Dan Sofer at Penn, and he has done LDL apheresis for me on these individuals. And it's no one's idea of a vacation, unless you like Philadelphia a lot, and making the trip, from either New York or this other individual lives in Long Island. But we've used PCSK9. It's one of the reasons that I will try that much harder to get PCSK9s approved. If I'm looking at somebody with a very high LP little a, taking 20% off of an LP little a of 125 is not going to matter a lot. It seems the literature from Brian Ferentz and others states that if we really need to drop LP little a substantially, unlike a statin. So if you have someone with 3-4 times the upper limits of normal, and if you've done genetic studies and they have the genotype of getting smaller molecules or other polymorphisms, then you really want to try to lower them as much as you can. And I think, going with a PCSK9 is a good idea, particularly when you give them a statin, and this is well known, that you're going to get anywhere from a 10 or 20% rise in LP little a, which can be quite a shock to a patient who gets a blood test done after initiating a potent statin in high dose, and they call you up and they want to know what kind of an assassin you are because you're raising their LP little a. So this is something important. And, with the approval of PCSK9 inhibitors broadened, you have the opportunities to do this. Thankfully, it's not as onerous to do as when you and I were struggling to get a PCSK9 inhibitor done, and we needed genetic studies.
You always tell me that one of the other reasons to find patients with LPA is because, and you know this better than anyone because you direct so many of these trials at our institution, is that you have the opportunity to offer them enrollment in clinical trials with drugs in development to lower lipoprotein A. And then you've had the unique opportunity to be hands-on with this. You're constantly telling me what the enrollment criteria are for our clinical trials. Can you walk us through the drugs in development briefly and where we are in that process?
Sure. So the first on the list was the ASO, the antisense oligonucleotide to Lp(a), which is pelacarsen. That trial had the misfortune of launching during the pandemic. So there was a difficulty in getting patients in, which delayed the closure, which they're anticipating to be the beginning of next year. Following that is a drug with a slightly different technology. It's called a small interfering RNA. It is, I should say that pelacarsen lowered Lp(a) 80 to 85%. It's a monthly injection. It seems very well tolerated. The next drug was olpasiran. Olpasiran is a small interfering RNA. It gets 90 to 95% Lp(a) reduction and is going to be dosed at 3 to 6 months. The next drug that is going to be coming out is lepodisiran, a very potent Lp(a) inhibitor with 95% plus Lp(a) reduction, and it's almost like vaccinating for Lp(a). As a matter of fact, the ACCLAIM trial, which is their outcome study, is one that has been modified to have a yearly dose put in it just to see how well they do versus someone getting it every 6 months.
That's amazing. So again, you're talking anywhere between 80 to 95% reduction in LPA, and in many cases, fairly infrequent dosing. It certainly is appealing and exciting for those patients. And I know that the first couple of trials are being done in very high-risk patients who already have heart disease or atherosclerosis, stroke, etc. But I think there's one drug right now in development, you and I spoke about it, where they're looking at primary prevention, high-risk primary prevention. And those are the patients that always come to us terrified because a family member has had some disastrous event, correct?
Absolutely. So this is the people in the ACCLAIM trial had it divided 65-35, where the high-risk patients, those with a high coronary calcium score, those with multiple cardiac risks, hypertension, kidney disease, particularly nephropathy, diabetes, the idiocy of smoking, all these things put together. These are the ones that they want to look at, and these are the ones I really wish it would have been buoyed the other way, because you are right. The word terrify is where these people are. I get more emails and notes and texts and phone calls. When are these drugs coming out? And you and I also know that regrettably, because of the designs of the study, the pelacarsen and olpasiran data may not motivate the insurers to allow the drug to be used in those who have not had a cardiac event, and it may not motivate the FDA to clear it in that way. So it's only hopeful.
As we anticipate the arrival of these exciting new therapeutic options, what can clinicians do now to prepare for integrating LPA into routine practice? And we've touched on a lot of this already, but just to wrap this up in a bow for those listening for us, what can they do today?
So do what the NLA said a year ago, which is test everybody, right? That's the answer. We're talking about when the needle is already in the vein, all you got to do is check one more box. And because it is 90% genetic, if it's completely normal, you never have to check again. And this way you at least know what's going on, rather than saying, Harry, I know why you had a heart attack at age 40, and it's really too bad we didn't know about your Lp(a). because we could have maybe lowered your LDL. We couldn't have necessarily mitigated your LP little a, but we certainly could have lowered your risk. And those kids of yours, they could have been protected too. So I think this is what we should be doing. And it's not an expensive test. You're not passing x-rays into anybody. You're not injecting dye. You don't have to fast for 24 hours and get a liquid diet. None of this has to go on. It's a simple blood test. And the interesting thing is there's only a couple of things that impact it beyond genetics. If your kidneys are bad or your liver's bad, that can impact it. Certain hormonal things like, estrogen therapy, testosterone therapy, menopause can influence it. But otherwise, most of this stuff is really a gift from mom or dad or both.
So it sounds like, normalizing it as part of your standard practice is one. Educating the patients about why it's important to know about it. I think, we've got new guidelines coming out in March. It'll be exciting to see where they position LPA in our current guidelines. In 2018, LPA was listed as a risk-enhancing factor, exactly as you've described it, that use it as a reason to intensify everything else. And then I think building awareness and collaborating across teams, you and I, we speak to our surgeons all the time about patients with early aortic stenosis. Did you check LPA on these patients? And talking to the pediatricians and talking to the OBGYNs, et cetera. You never know where you're going to get your patient referrals from. And so that awareness is, as you've talked to, is really so key and important.
Jamie, you and I talked about a couple of patients that younger women are frequently ignored in this. But if they have a high LP(a) and they're contemplating pregnancy, you would like to know whether they have aortic valve disease. And I think that it's that easy. And people don't think about the applicability, but yet the prevalence of this lipoprotein is one that makes you really happier when you've looked.
So I have a question for you as a cardiologist, and this comes up often when having discussions with folks about this. We know that there is this increased risk of calcific aortic stenosis, supravalvular aortic stenosis in patients with LPA, and it probably has to do, as you mentioned, with the deposition of these oxidized phospholipids on the valve surface. You're a cardiologist. You have really good ears. You know what aortic stenosis sounds like. Is your exam enough, or do you do routine or intermittent echocardiograms or recommend them for these patients?
In people with a high LP(a), I am very motivated to not completely trust my ears, because what I'd like to because it may be, if it's a soft, kind of benign sounding murmur, it may be a flow murmur, you still don't know exactly what you're listening to. And if you're looking at an aortic valve that is already fibrotic, a little calcified and thickened, you have something that needs to be followed. And I think it's an important feature because it can impact many things: participation in sports, pregnancy, operations, and just how they're going to conduct their lives. So I think it's, again, ultrasound is not a toxic study material. So it doesn't cost a fortune. And yet when you get it, it's good to know that you're following something that could have very serious implications.
This has been a great discussion. I just want to review quickly. We talked about how LPA is a risk factor for atherosclerotic cardiovascular disease and aortic stenosis. You mentioned it's seen in 20% of the population. That's a couple of patients a day, depending on how many patients you see. There are currently major guidelines from AHA, NLA, ACC, and the Europeans recommending that every adult patient be checked at least once in their lifetime. As of today, that's out there and recommended. There's a lot of misconception that LPA is not actionable, and you've spoken to all of the things that stem from telling people about the presence of elevated LPA, from more aggressive treatment of modifiable risk factors to family screening to enrollment in clinical trials and potentially the role of either PCSK9 inhibitors or LDL or lipoprotein apheresis. If we identify someone and enroll them in these trials, then hopefully we'll find answers quicker. And we've got a bunch of drugs on the horizon that lower LPA anywhere from 80 to 95%, some reporting out somewhere in the next year or two. And that's incredibly exciting. And so incorporating testing and evaluation and counseling into current practice, I think is where we should be going right now. So Howard, I want to thank you for your insights, your counseling, and your role in driving this here at NYU and nationally. It's been an excellent discussion, and thanks to our audience for listening. Please remember to take the post-test evaluation to receive CME credit. And also please tune in for additional episodes within this series. In our next episode, I will be speaking with Dr. Zahid Ahmad, and we will be discussing and recognizing the treatment of lipodystrophy. Thank you very much.
Thanks again for listening to MedEdTalks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.